good day and some good afternoon. Joburg Fertility is going to present a very interesting topic. I'm actually very happy to present this topic, which is a very, very common topic. And I've started, with it because it's the most common condition which is found in African women. Firstly, we know that the fibroids affect 30 to 70% of women, especially of African descent. But in case of European, then you're looking at a lesser, prevalence of this condition. We know that fibroids got a negative impact on the fertility of women. And we also know that mostly the submucosal fibroids associated with 70% reduction in delivery rate. Therefore, myomectomy is actually the only treatment which is viable at the moment and which we know is effective, especially when you're looking at treating infertility in this condition. Then prevalence of uterine fibroid, it's really about 80%, as I said, in African women. And then there's high prevalence as well in other, tribe, but it's more common, as I said, in African women. Now, what may be the presentation of fibroids in these people or African women? Commonly, you find that you may have abnormal bleeding, is the common, heavy menorrhagia, a lot of bleeding, and with clots and even prolonged. Then it may be associated with pain as well, and in the pelvis, which some women may complain of for a long time. And the other important thing, on examination, may find out they have a pelvic mass. Although those are the common presentation, infertility seems to be the main presenting in this reproductive group of women. As well, if we look, there may be other, organ which may be affected with fibroid. By that, I'm thinking of the ureter, may be obstructed because of huge fibroid actually causing obstruction there on the ureter. You may have bladder symptom because of the fibroid as well, which may give you agency and even urinary incontinence. Then the other important thing as well is to look at the bowel. Really, bowel may be affected by fibroid because all these organs, they pass in the pelvis, and therefore you may present with obstruction. Therefore, it's not that uncommon to have such a situation. Fibroid may be contribute to adverse obstetric outcome. In other words, if you're pregnant with fibroids, we know that you may experience some problems there. One important thing may be preterm labor associated with fibroid in pregnancy and even preterm delivery. And the other important thing you have to remember as well, it's implantation of the placenta, which what we call placenta previa. Therefore, abnormal placenta plantation due to the fibroid. Also, the baby may be affected. In that case, we're talking of intrauterine growth restriction. And there's high rate of women who have fibroid to deliver by cesarean section, as well as in those women, you can expect high, prevalence of actually the postpartum hemorrhage, which actually may increase the maternal morbidity and mortality. Now, why really fibroids are so important to somebody who's doing fertility and looking after women who become pregnant? By now, through a lot of research, we have seen some few, important information have come up. Then we know that fibroid may obstruct the gametes transport. In other words, after fertilization of the sperm and an egg, that transport into the uterus for implantation may be affected. There may be dysfunctional contractility of the uterus itself, which prevent implantation. There may be also some endometrial receptivity, which may be abnormal. In other words, in order for that the embryo, the blastocyst to implant into the uterus, it may not be able to do so. And abnormal vascularization, that is a very important fact. In other words, where the fibroid is located in the uterus, you may find that there's a decreased blood flow to the endometrium where implantation of the baby is supposed to actually grow. Therefore, there's also lack of blood going to that direction. There's maybe chronic inflammation in the endometrium itself or the inside of the cavity. And also we know now with some research, there's abnormal hormone or milieu which is related to the growth of the fibroid around even in the intramural or in the submucosal area. Now, it's very important as well to know the classification of fibroid. Fibroid, we really classify it into two groups, which is more clinical, like submucosal. It means they are in the uterine cavity, in the muscle, intramural, and the subserosal. It means it's outside. Although this is it's a simple classification, but fibroid may differ in where they are located. You may look as well as other classification using a hysteroscopy, or when you're planning that, in that case, you say type 0, which is actually pedunculated right in the cavity, or type 1, which is actually more than 50% is outside the cavity, but the other one is inside. And type 3, it's a fibroid, which is difficult. Probably we have to decide whether to do it through a hysteroscopy or with a laparoscopy. It's very important, especially that hysteroscopic classification, so that we can have a better outcome as well. Now, how do we diagnose fibroid? That's the most important thing as well. The most important thing is really examination. Some people may have a mass which is palpable through a pelvic examination, but the cornerstone in diagnosis, I think, is an ultrasound, either pelvic ultrasound or abdominal ultrasound, where you can see the masses originating from the uterus, and then you can even measure them and even look at the blood flow, doing a Doppler on that. And then the other important thing, if they are in the cavity, you can do hysteroscopy or do other imaging, which you may see the fibroid in the cavity. Laparoscopy is also more important to diagnose and even to treat, and even other methods, maybe MRI, in which you can be able to count the number of the fibroid and how big are they and so forth. It can also be actually used and effective. Although the MRI may be very expensive, but it gives a lot of information, especially in planning surgery in these women. In management of fibroid, I'm just going to tackle the most important. Really, you can go medically, and then with actually, reduction of the size of the fibroid. And though after the treatment and the side effect related to medication, you can stop, and sometimes you cannot even go more than 6 months on medication. However, with new, information coming in, there may be, some in the horizon good medication which are coming in, which may be effective in helping those patients with fibroid. But all those medications are still under study at the moment. Laparoscopy is actually the favorite method of removing the fibroid which are big in the uterus. And then you can actually in the cavity use the hysteroscopy to remove those. You can also use robotic surgery, which is actually, gaining more momentum with this fourth revolution. And therefore we're getting more people, getting expertise in actually robotic surgery. There may be other treatment like UIA, which uterine artery embolization, which we're not recommending at the moment, because really there are anecdotal information that you can, pregnancy do come out. But, as a surgeon with a lot of experience, I've seen a lot of problem, especially a lot of endometrial adhesions after uterine embolization, and as well as infection, and even a patient with recurrent miscarriage, which is directly related to, decreased blood flow to the endometrium. Therefore, thank you. This was a nice topic. I enjoyed. Thank you. Bye-bye.